Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Alice Gallo de Moraes.
Hello, Chest Journal podcast listeners. I am Alice Gallo, an intensivist at Mayo Clinic in Rochester, Minnesota, and I have the pleasure of having Dr. Brian Erstad and Dr. Sid Patanwala with me today. We're going to talk about their paper on comparative effectiveness of albumin versus no albumin on renal replacement therapy and mortality in patients with septic shock and renal replacement. Welcome, Dr. Erstad and Dr. Patanwala.
Thank you very much, and feel free to call me Brian.
That sounds good.
Thank you, Dr. Gallo, and you can call me Sid as well.
Sounds good. So, Brian, how about we start with you? So tell our listeners a little bit about you. Where are you joining us from? And what in your clinical work inspired you to look into albumin in renal replacement therapy patients in the ICU?
Oh, thank you, Alice. Thank you for having us. I've been around a long time. I'd worked in a couple of community hospitals before getting another degree, doing a residency, and ending up in academia. Have had a 24 accredited specialty residence, throw in a fellow or two, and primarily worked in surgical trauma ICU settings. And more recently, as I'm getting near the end of my career, I've been doing more research. I'm tenured full professor, and so that's where I'm at now. And as for, by the way, at the University of Arizona in Tucson, Arizona. For me, what got me interested in, I've had actually a long-standing interest in albumin. And I mean long-standing. At some point, we could maybe do a podcast on the history of albumin, because I've done quite a bit of looking into it. And way back to when albumin was first fractionated in preparation for World War II, even at that time, the investigators were noticing differences between what isooncotic albumin, which is your 4 or 5%, and hyperoncotic albumin, which now is 25%. At the time, they were using 25%. But even in those days, like I say, they actually had a difference in the warning label on the 25%, recognizing that it was going to have different characteristics than the 4%. And there were some other studies that came up over the years that were kind of unnoticed, but also pointed to this difference between the solutions. And I'll just give you one example. There was a study that was in the Journal of Trauma where they used hyperoncotic albumin to resuscitate 4 children with burns, and all 4 of the children died. They received just the resuscitation with hyperoncotic albumin and no crystalloids, and they postulated that you had this big increase in the oncotic pressure in the vessels from all this excess albumin, and then it all flooded back across, and all of the children they died, and they had pulmonary edema. And so we can talk later about potential mechanisms related to kidney injury, but this is what got me interested. Were the differences between albumin, hyperoncotic and isooncotic albumin products, and this is why I've been concerned with a lot of previous studies where they would use both. They would just refer to giving an albumin, and they would use either the isooncotic or hyperoncotic, and there are clearly differences between the two.
Yeah. How about you, Sid? Where are you calling us from? I know you're in a very different time zone, but where are you calling us from? And what got you inspired to look into albumin with Brian?
Yeah, thank you, Dr. Gallo. So I'm joining from Sydney, Australia, so a little far away from Tucson, Arizona. And so I am chair of clinical pharmacy here. And I'm jointly based between the Royal Prince Alfred Hospital and the University of Sydney, and I'm a critical care pharmacist by background. And so I think my interest in albumin, I guess the first time I really heard about, was early in my career with the SAFE trial. And I know many of the listeners might be familiar with the SAFE trial, which was a comparison of albumin and saline and crystalloids. Back then, and it didn't show any difference at that time, and but throughout in the following 20 years, we still continue to debate it, and there still remains some clinical equipoise with these variety of different subgroups, and that's what we thought, that what could we do which is difficult to do in a clinical trial, and something where we could look at subgroups, and that's what got me interested in it. Obviously, my institution, the Royal Prince Alfred, was one of the major sites for the SAFE trial here in Australia, and we have one of the largest ICUs, and that I guess is part of the reason why I've been so interested in it.
I love that. Thank you both.
And by the way, I'd throw in, Alice, that Sid and I have worked together. It was many years ago, but we've known each other for quite a while.
I love that. That's awesome. Again, thank you both for being here. I'm really excited to talk to you about your work because, like I mentioned before, I loved what you did. So tell our listeners, and Brian, we're going to start with you for this next one. Tell our listeners about the background for this specific question, looking into albumin versus no albumin in renal replacement therapy, specifically in patients with septic shock.
Yeah, and so again, a couple things that have been sort of mixed up in the literature. A lot of the previous studies combined patients with sepsis. In the past, prior to the change in definitions, they combined patients with severe sepsis, and they would often lump them in with patients with septic shock. And so you look at some of the key trials that have been discussed in the past, and besides not necessarily separating iso-oncotic and hyperoncotic albumin preparations, they didn't separate out these subgroups of patients with sepsis. And again, there's, as your listeners all can imagine, a big difference between a patient just meeting the criteria for sepsis and then meeting the criteria for septic shock. And so right off the bat, we wanted to focus in on again, a specific group rather than lumping the spectrum of sepsis patients together. And then I can let Sid add in, but at some point, if we want to talk about the postulated mechanisms as to why the albumin, the hyperoncotic albumin in particular, might increase the problems with the kidney, we can talk about that. But I guess for now, I'll defer to see if Sid has any additional comments.
Yeah, so the specific question about albumin versus no albumin in this particular cohort of septic shock and with patients who have renal impairment, this came from essentially when you looked at some of the subgroups of the trials, it showed that at the high end, at the severe end of, at that time, sepsis was defined as severe sepsis and septic shock. So using that definition, they showed that perhaps there was some benefit in patients who are, had the severe end of sepsis. And that was one of the reasons we wanted to look at that particular group. The other issue was the renal impairment, and because of some of the mechanistic reasons and some of the observational studies that were published after the SCCM Society of Critical Care Medicine guidelines, there were some observational studies using some other databases that showed that maybe the benefit was in people who already had some sort of kidney impairment, and that was the reason for the population.
I love that. Before we move forward into methods, Brian, I do want you to tell our listeners about the mechanisms, potential mechanisms. I want to hear it. Please.
Okay. Well, there's a couple that were postulated. There was a paper in 2008 that basically discussed the risk associated with hyperoncotic colloids, and so it wasn't just hyperoncotic albumin, but it was also the starch products at the time, et cetera. And they actually did find that there was increased problems with the hyperoncotic albumin. and that the use of hyperoncotic albumin was even associated with an increased risk of ICU death. And they postulated two reasons. One was related to the Starling equation, and this would still hold true, by the way, with the revised Starling equation, but at the time, they talked about how glomerular filtration pressure decreases as intracapillary oncotic pressure increases more than hydrostatic pressure. And hyperoncotic albumin obviously would add to that. So that's increasing that oncotic pressure within the vessel more than the hydrostatic pressure, intending to, again, decrease GFR. And then another possible mechanism they discussed at the time was that they were finding these lesions, they referred to as osmotic nephrosis, that they were finding these lesions in the kidney. And so those were two of the postulated mechanisms that were circulated at the time.
Thank you so much for sharing. I was very curious. Sid, go for it.
Yeah, I guess I would say that, we started off, but to be honest, we started off thinking that it would be positive. We were looking for the cohort which would benefit, right? So from a mechanism perspective, I mean, it's mixed, and there are so many different studies, and I guess some show that it has beneficial effects. I mean, these anti-inflammatory effects, effects on nitric oxide, effects on better hemodynamics in some of the studies, and then you have the negative effects that Dr. Erstad was talking about with this osmotic load that might go to the kidney. So I think from a mechanism perspective, you could sell it either way, and we came out on the other side, and that's why we were almost had to now think about why it could have been harmful in the hyperoncotic subset.
And then if Alex, I could add to that, because I felt like I haven't been giving it, because Sid has a very good point that he just made, that, you could lump albumin's actions into a couple of major groups. One is the oncotic effects and strictly related to those oncotic actions, but then you could also lump it into what's been referred to as pleiotropic effects. And I agree with what Sid said, that at the time, a lot of people were really focusing on all these beneficial pleiotropic effects and how those could actually improve outcome. But I'll put one caveat to that whenever I hear that, and that's that the albumin in your blood is not the same as the albumin that we administer, the commercially available albumin, because it's actually altered both during manufacture and actually even at post-manufacturing. And they've shown this in studies where the binding capacity, for instance, is reduced. It loses some of its antioxidant activity. And so for the listeners, I just want them to realize that, again, the albumin in your body is not necessarily the same as the exogenous albumin that you're giving. But I do agree with Sid that again, we sure didn't go into this thinking it's going to be negative. It could have gone either way.
Absolutely. And I confess, when I started reading, I thought it was going to be negative as well. So with that, let's talk a little bit about your methods, how you designed your study. And Sid already touched a little bit on the setting, but Sid, could you tell us a little bit more about design, setting, populations, and all of that?
Yeah. And so this, very briefly, for the listeners, I'll say that. So this is an observational study. It involves hundreds of hospitals in the United States using a national database, and we ended up with close to 10,000 patients overall. The groups were so the cohort was people with septic shock and who had some renal impairment. So they had to have a eGFR of less than 60, and but they couldn't already have, on the day of admission, they couldn't already have end-stage renal disease. So those people were excluded. Mm-hmm. And basically, so the groups were those who received albumin early, within 24 hours, or those who did not receive any albumin at all in the hospital. And so those were sort of the comparison groups. we chose a methodology of so there are there are various methods of with observational study designs and for comparative effectiveness. And we decided on inverse probability of treatment weight, which is one of the propensity scoring methods. And, people debate what is the best method all the time. We, after a lot of conversations with one of our other co-authors, Hemal Mehta, who's from Johns Hopkins, is a epidemiologist, methodologist, we felt that this would be the best method. And one of the reasons is that it uses weighting. You can retain the full sample. So if you did a propensity score match of 1-to-1, you lose a big part of the sample.
Yeah.
But if you use a weighting, you can retain the full sample.
Yeah.
And so in a way, and you can, so it gives you a lot of better options and for actually making sure that the groups are balanced when you're comparing. So in a way, it reminds you a lot like a clinical trial, because at the end because you're doing the adjustment up front rather than later, like in a regression analysis. And that's the part of it that I really like, because for clinicians, you can just look at it and you can look at the final groups when you look at our table 1, and you can see that, okay, they're very similar. And that's what the reader should, take away, is that, they're similar groups, even though prior to weighting, they may have looked differently. So that was one of the reasons for that methodology. The other thing I just wanted to point out is that in terms of our outcome, we debated this a lot as so the investigator team, because when we look at a renal outcome, there a lot of studies look at the KidGO definitions of acute kidney injury, which we did as a secondary measure, but we thought that using serum creatinine as a biomarker for the primary outcome wouldn't be ideal, and especially because there's so many assumptions that go into what is the baseline serum creatinine value. So we thought that using a more well-defined outcome, like whether or not someone got renal replacement therapy, would be a lot preferred. And I know people have a lot of opinions on this aspect, but at least our outcomes are pretty clear, and it's essentially the MAKE outcome, the major adverse kidney event, without the EGFR or serum creatinine components.
Fascinating. I love it. Brian, anything to add from your standpoint?
No, I think Sid summed it up pretty well. The issue with the creatinine in our critically ill patients, that even applies to the large trials where getting this baseline is just very challenging. And there's assumptions that have to be made. There's ongoing debate, even in the nephrology literature, as to how to handle those patients when you haven't got that baseline creatinine, a stable baseline creatinine.
Yeah, absolutely. So tell our listeners then what were your findings? What were the results of your investigation? Brian, start or Sid want to start? Go, Sid.
I can. So the findings were that in these patients with septic shock and kidney impairment, so albumin, the composite outcome of whether or not they got renal replacement therapy or they died during hospitalization, those patients who got albumin had a higher proportion of them required RRT or had in-hospital mortality. Now, if you separate out each of those individually, it still was higher for each of those outcomes, and that's the main finding. But then I think it's also important to mention that it was different. The findings were different between the 5% albumin and the 25% albumin. And this is what we were talking about initially.
Yes.
Is that there was no difference in the outcomes with the 5% albumin, but there was increased risk with the 25% albumin. So I think that's a really important thing for clinicians to know, and that's one of the reasons why it's also in the abstract to highlight.
Yeah. I was very surprised also. Yeah, because again, like when I started reading, I really thought it was going to be no different. But I was very surprised as well with the fact that patients with lower baseline albumin, there was also significantly favoring not to use albumin, that they had worse outcomes, which is something that we hear kind of like in the clinical setting, that patients with lower albumin baseline should be receiving albumin. So I thought that was a very important finding for people at the bedside as well.
Yeah, and what I would say is I'd tell readers to look at the right hand side of table 1, which has the adjusted values, and after adjustment, both groups would have a baseline albumin of 2.9. So I just want to say that the groups were matched in terms of serum albumin for the adjusted groups.
I guess what I would add to that, and this again gets a little more into the mechanistic aspects, but serum albumin, we know is this acute phase. I'll call it acute phase depressant. We know that it goes down with stress, inflammation, etc. And so a serum albumin is not reflective necessarily of total body albumin. And so that's why, to me, that virtually all the studies to date where they've tried to look at just increasing the albumin level, I've heard it analogous to taking your finger and pushing the gas gauge on your car up to full. It's not going to mean your car's going to go any better, have that gas. And it's again just a marker of what's in the blood at the time, and not necessarily your total body albumin. And it's related to that shifting that occurs with stress and inflammation. And I'll say, in terms of the results, I wouldn't have been surprised, like you, Alice. I would not have been surprised if there had been no differences overall. Yeah. Because obviously everything tends to be, it's always a power issue, and you just expect things to be no different. But I must say that if we are going to find a difference, this is the way I expected it to be. I would have been much more surprised if we'd have found, for instance, harm with 5% albumin. There's just nothing that in the literature, to me, previous literature, that would have suggested that's the case. But the 25%, as I alluded to when I started talking, that one, let's just say it didn't surprise me. And
Brian, I've mentioned this to you, before the call, but one of the things that I guess supports, in a way, the results is that there's a trial called it's called the Albix AKI, I believe, which is also done in Australia, but this is in cardiac surgery patients, so maybe a different cohort. But that one hasn't been published, but we listened to the presentation here, and that has also had shown more AKI with the hyperonchotic albumin. And so even those authors, and this was the clinical trial, and even those authors obviously went into it thinking that, either would be beneficial or no difference, and the hyperonchotic ended up with poor outcomes. So that is, so in a way, it's almost like it's being validated in a way with this other clinical trial coming out. But as you know, there's also the ARIS. We mentioned this in the discussion of the paper, but there's the ARIS trial. I believe it's coming out of Germany, and that is in patients with sepsis, severe sepsis, and that is looking at, they're currently enrolling people with hyperonchotic albumin. Yeah. And so that would be very interesting to see.
Although if I can add to that actually the study limited to a septic shock, and they are using hyperonchotic, but unfortunately the trial had to be terminated due to insufficient enrollment. So I'll be,
okay.
I think I'll be surprised, Alice, this is another one, I'll be surprised if there's a significant difference giving the early termination of the trial.
And Brian, going back to what you were explaining, both when you were introducing yourself and then when you were explaining to us potential mechanisms for your findings, and in general, hyperonchotic albumin, we have probably significant data in the past 15, 20 years that hyperonchotic anything can be harmful, right? In several different populations. So I think that probably is one of the important messages of our conversation, at least.
Yes, although, like I say, there's always, ever since albumin first came out, and literally a lot of the early studies, by the way, were published in the Journal of Clinical Investigation between 1941 and 1944. If the readers would look back, you'd be surprised how many studies were published right after the fractionation of albumin had occurred. And, again, as I said, even back then they started to elucidate some of these different mechanisms of albumin, but I've always been a little bit suspicious of the so-called pleiotropic effects, and that's what everyone seems like they've harped on in the last 10 or 20 years. It's not the oncotic actions. It seems like the focus is on the pleiotropic effects, and as I said, the fact that the albumin we're administering isn't the same as what's in the body, that likely explains some of the issue. There's even a concept that's in the hepatology literature that's fairly well known, but less known in the critical care literature. It's known as effective albumin concentration. Yeah. Basically, they recognize the defects in the albumin that we're administering, and so they're trying to find ways to actually look at the effective albumin concentration. But again, right now that's not ready for prime time because we can't perform those measurements in clinical labs.
Yeah.
And outside, sorry.
Go No, go ahead, Sid. Go ahead.
And outside, besides albumins, I think if you're talking about the starches, other hyperonchotic things. So there's a sort of a story here with hyperonchotic products, and with the starches now obviously falling out of favor with acute kidney injury and other things. So I think, So in that aspect, it's very similar.
Yeah, that might have been what you're referring to, Alice, for this longer history, because the starch products now, in my mind, they should be totally avoided in critically ill patients. But we've known for a long time that they can cause kidney injury and even bleeding, increased mortality, and the only other colloid that have seen some use are the dextrans. But I've done surveys when I've given talk on the subject, and I've asked audiences, and no one's using the dextrans. So every once in a while, I'll find an orthopedic surgeon who maybe uses it for its anticoagulant effect, and then get a little bit of a plasma expansion. But I virtually never see hands go up when I ask in a more critical care type population.
Absolutely. And going back to your amazing work, let's start with Sid. Anything in your findings that was, again, I know at the beginning you thought it was going to be no difference, but anything in your findings that you did find it surprising?
I think I think the main finding of the hyperonchotic, to be honest, I thought either the reason we picked the cohort with some renal impairment is because we thought that would be the group that would sort of benefit the most based on these previous observational studies. So our study, in a way, and the difference between our study and the previous ones is that they didn't separate out the types of albumin, and I think that's an important point, is to basically separate them out. Mm-hmm. And so I think that was one of the things that sort of surprised me, and but in terms of the other thing, if you notice in there that I'm still trying to figure out is that those people who are not mechanically ventilated, if you look at the subgroups, they actually benefited the least if you're not mechanically ventilated. And we had to really think about why that would be. The other subgroups, like if you have kidney disease, or if you already had a higher stage of injury at baseline or lower GFR, okay, that sort of, we could explain that. But the invasive mechanical ventilation was difficult to explain, but we came up with our theory, which we've put in the article. Yeah. And so I think that was something different. Brian, I don't know if that struck you as well.
Yeah, it did. And it's back to this sort of mechanistic thing that we talked about before, where we know that albumin leaks across the capillaries. And the question has always been, well, how quickly? But we know the more severely ill patients are, the more quickly it leaks. And so it used to be thought that when you give hyperoncotic albumin, 25% albumin, you're going to get 4 times the plasma expansion of like a crystalloid. And there's plenty of studies. Students had alluded to SAFE. They showed that ratio, instead of being 4 to 1, was something like 1.2 or 1.3 to 1, much less than we thought. And the reason is because that albumin in severely ill patients very quickly leaks across the vessel and into the interstitium, where you're losing that benefit. And obviously, when it's leaking into the interstitium, it's pulling all those excess albumin molecules are pulling fluid with it. So, isooncotic is sort of self-contained. It's got just the amount of fluid it likes. Hyperoncotic has all those extra albumin molecules that are then attracting fluid towards it. Well, guess what? that fluid then is all surrounding, the interstitial, the interstitium, and you're getting interstitial edema. Eventually, you're encroaching those alveoli, and eventually you can flood them and, for instance, get pulmonary edema. And obviously, that's something that it's difficult to look to. We unable to assess it clinically in our study, but that's the kind of thing. Just related again to the oncotic, the fluid aspects of it, setting aside the pleiotropic actions. That's the kind of thing. The thoughts that we might entertain mechanistically as to what's going on.
Yeah. And I am having a blast talking to both of you, and we can go for hours and hours. However, all good things must come to an end. So I was hoping to start with Brian, and you tell our listeners like a couple of take-home points from this work that you would like our listeners at bedside, taking care of patients with septic shock on a daily basis who need renal replacement therapy. A couple of take-home points.
Yeah, my take-home points would be, especially as you're looking at previous literature, be very careful about studies where they combine patients with different sorts of sepsis, like sepsis, septic shock, and be very careful when you're looking at studies where they combine albumin products, isooncotic and hyperoncotic albumin products, because again, there's just all sorts of reasons why you could have differences in outcomes because of those things. And secondly, I'll point out that, remember, we did include patients that septic shock and kidney impairment on hospital admission. And that's an important point, that kidney impairment on hospital admission, because, at least some of the trials where their subgroups suggested there might be benefit didn't either report that or at least they didn't say that was present. And so, that's something in my mind, just another thing to keep in mind. But I would love to see this kind of thing be repeated. It might not. To me, it's probably unlikely to be repeated in a large RCT because it's difficult to have the 6,997 patients that you have in a SAFE trial. But I'd love to at least see maybe it's repeated in another large database study to see if it gets similar results.
Yeah. How about for you, Sid? What are some of the take-home points that you would like our listeners to be left with?
So I think it's good for the listeners to think about what the population is. For example, the average eGFR was around, close to 30 when you look at it. So it gives you a sense for when you're trying to apply the results to your patient. Just think about what the characteristics of this study, the sample the sample is. And the other thing is to think about is we're not, if you're thinking about using albumin, I guess, from 5% albumin, it's, it still seems to be, there's at least we didn't find any harm. So that's not, but when you move forward to the next step, and I'm just thinking, why would someone use a hyperoncotic albumin when at least if it was neutral, then given that this is an observational study, I acknowledge that, but if it was neutral, then it wouldn't be an issue. But even moving forward, I'm thinking of if there was a clinical trial, why would people want to enroll in such a trial? And that's something I just want to get readers to think about.
Thank you so much, both of you, for joining me today for our Chest Journal podcast. I had a blast. Again, we could have stayed talking for a couple more hours. And Brian, I'm gonna suggest that we do a historical albumin podcast. And for our listeners, I'm Alice Gallo. I'm an intensivist at Mayo Clinic in Rochester, Minnesota. And I had the absolute pleasure of talking with Dr. Brian Erstad and Dr. Sid Patanwala about their paper talking about comparative effectiveness of albumin versus no albumin on renal replacement therapy and mortality in patients with septic shock and renal impairment. Please read their paper in the Chest Journal, and thank you for listening to our podcast.